ഹായ് ഫ്രണ്ട്സ്, വെൽക്കം ടു മൈ യൂട്യൂബ് ചാനൽ. നിങ്ങളൊരു നേഴ്സാണോ? അല്ലെങ്കിൽ നിങ്ങളുടെ പരിചയത്തിലൊരു നേഴ്സ് ഉണ്ടോ? എങ്കിൽ ഈ വീഡിയോ തീർച്ചയായും ഉപകാരപ്പെടും. ഇന്ന് ഞാൻ എടുക്കാൻ പോകുന്ന വിഷയം പ്രഷർ അൾസേഴ്സ് ആൻഡ് ഡ്രസ്സിംഗ് ആണ്. അപ്പോൾ നിങ്ങൾ ഈ വീഡിയോ ലൈക്ക് ചെയ്യുക, സബ്സ്ക്രൈബ് ചെയ്യുക, തൊട്ടടുത്തുള്ള ബെൽ ബട്ടൺ അമർത്തി നോട്ടിഫിക്കേഷൻസ് എനേബിൾ ചെയ്യുക. ഇന്ന് ഈ വീഡിയോയിൽ ഉൾപ്പെടുത്താൻ പോകുന്ന കുറച്ച് കീ പോയിൻറ്റ്സ്: definition, pathophysiology, causes, clinical manifestations, pressure point areas, client susceptible to pressure areas, diagnosis and assessment, Braden scale, stages of pressure ulcer, wound care management, wound dressings, algorithm for dressing, negative pressure wound therapy, newer research, prevention of pressure ulcer, algorithm for pressure ulcer, and complications. First, we can see the definition. Pressure ulcers are type of injury that breaks down the skin and underlying tissue when an area of skin is placed under constant pressure for a certain period, causing tissue ischemia, cessation of nutrition and oxygen supply to the tissue, and eventually tissue necrosis. Pressure ulcers are also known as bed sore, pressure sore, decubitus ulcer, and pressure injury. Next is medical device related pressure injuries. These result from the use of devices or designed and applied for diagnostic or therapeutic purposes. Examples: elastic stockings, oxygen tubing ulcers, CPAP bypass facial ulcers, tracheal pressure ulcers, cervical collars, and NG tube ulcers. These are the medical device related pressure injuries. Next is pathophysiology. When pressure increases even slightly above this capillary filling pressure, it will leads to microcirculatory occlusion, that leads to ischemia, then it leads to tissue death and ulceration. This is the pathophysiology. Next is the causes. Direct causes and indirect causes are there. Direct causes include pressure, shear, friction, immobility, loss of sensation, and combined pathology. Indirect: mobility problems, poor nutrition, health conditions like diabetes, heart failure, renal failure, and COPD, aging skin, incontinence, and mental health conditions. Clinical manifestations include redness, heat, tenderness, and discomfort in the area. The area becomes cold to touch and insensitive, local edema. Later, the area becomes blue, purple, or mottled. Due to continued pressure, the area circulation is cut off, gangrene develops, and the affected is sloughed. The pressure point areas in supine position includes occipital bone, scapula, elbow, sacrum, heels, and ankles. In prone position, ears, mandible, sternum, knees, ankles, and toes. These all are the pressure point areas in prone position. In side-lying position, ears, scapula, ribs, greater trochanter of hips, medial and lateral condyle of knee, malleolus of ankle joint. If the patient is on wheelchair, the pressure point areas include tailbone or buttocks, shoulder blades and spine, backs of arm and legs where they rest against the chair. Next is client susceptible to bed sore. Actually, ill clients whose general condition is rapidly deteriorating, elderly bedridden clients who make very little movements in bed, obese clients, very thin and emaciated clients having very little subcutaneous tissue to pad the body prominences, sedated clients, paralyzed clients who have suffered spinal cord injuries. Neurological clients with a lack of sensation as that they cannot feel any irritation of the skin, edematous clients, especially those with edema of the sacrum and buttocks, malnourished clients with the protein and vitamin deficiencies, agitated clients restrained, surgical clients with limited movements, clients on complete bed rest or with limited movements. Next is pressure sore risk assessment scale. It includes Braden scale, Norton scale, Waterloo scale, pressure sore status tool, Sissing scale, Bates-Jensen wound assessment tool. First, we can see the Braden scale. In Braden scale, there are 6 parameters. First one is sensory perception, second moisture, third activity, fourth mobility, fifth nutrition, and sixth friction and shear. The maximum score is 23 and the minimum score is 6. 9 or less very high risk, 10 to 12 high risk, 13 to 40 moderate risk, 15 to 80 mild risk, 19 to 23 generally not at risk. Then push tool. It's not a pressure sore assessment tool. It's a pressure ulcer scale for healing, wound healing. Then stages of pressure ulcer. It includes stage 1, 2, 3 and 4. In stage 1, non-blanchable erythema of intact skin, edema, induration, warmth over a bony prominence. In stage 2, partial thickness skin loss involving epidermis, dermis or both. In stage 3, full thickness skin loss involving subcutaneous tissue. And 4, it involves muscle, bone and supporting structure. And stageable includes entire wound base covered by slough or a scar, full thickness skin loss. Deep tissue injury means unknown level of tissue injured below skin and skin will be intact. These are the stages of pressure ulcer. Stage 1, stage 2, stage 3, stage 4, unstageable and deep tissue injury. Next is the management. First is the pressure relief. Reposition the patient. We have to reposition the patient minimum of 2 hours. Then mattress and cushions are used. Then some silicone soles, silicone elastomers, toe separators are used for preventing bed sores. Next is the nutrition. Protein helps in fibroblast proliferation, collagen synthesis, angiogenesis and immune function. In enteral formulations, protein can be in the form of intact proteins, hydrolyzed proteins or free amino acids. The NPUAP EPUAP recommends a global protein intake of pressure ulcer healing of 1.25 to 1.5 gram per kg of body weight per day for patients with stage 3 and stage 4. 1.5 to 2 gram per kg. Then vitamin A. Then vitamin C increases resistance to infection. Then iron improves tissue oxygen delivery. Copper has a role in collagen cross-linking that is required for the reconstruction of tissues. Manganese has a tissue generating capacity. Then zinc is an antioxidant. Vitamin is critical for the production of prothrombin and other clotting proteins. Adequate fluid intake is necessary to support the blood flow to the wounded tissues. Next is cleaning and debridement. Surgical debridement, mechanical debridement, enzymatic debridement, biological debridement or maggots and larval therapy. In mechanical debridement, cleansing, ultrasound and laser is included. Next is wound dressings. Alginate dressing, foam dressings, gauze dressings, honey dressing, hydrocolloid dressing, hydrogel dressing, silver dressing and transparent film dressings. These all are the dressings used for wound care. Alginate dressing. It's made from seaweed. It's absorbent. It's required infrequent changes. Then it's used for infected wounds, moderate to high discharge, and it's expensive. Next is foam dressings. It's made from polyurethane. It's absorbent. It provides padding. It is used for infected wounds, fragile surrounding skin, stage 1 and for prevention, and it's expensive. Next is gauze dressing. It's in limited use. It's inexpensive. It is used for micro debridement. It requires frequent changes. Large complex wounds with exudate or biofilm, it's used. Next is hydrocolloid dressing. It is made of a foam or film polyurethane. Sodium carboxymethylcellulose based gel material is used. It is used in wounds with minimal discharge 2 and 3. It's absorbent and it's inexpensive. Next is hydrogel dressing. It's gel based and at 90% water, hydrating dry or dehydrated wounds moves easily, uninfected granulating wounds. Next is silver dressings. It has bactericidal property. It is used in infected wounds. Remove once infection is cleared. Next is transparent film dressing. It is to protect stage 1 or 2 ulcers where the skin remains intact. It's a barrier from bodily fluids. It's not porous, can't rip the skin on removal. It's used in stage 1 and stage 2. This is the algorithm for dressing. Next is antibiotics. All pressure sores do not require antibiotics. Only the infected wounds require antibiotics and they are adjunct to surgical debridement. Topical antibiotics should be avoided because their use may increase antibiotic resistance and allergy. Antiseptic cream may also be applied topically to pressure ulcers to clear out and any bacteria may be present. Next is negative pressure wound therapy. Before application of negative pressure wound therapy device, the wound must be adequately debrided. It assists in granulation, applied controlled localized negative pressure to help uniformly draw wounds closed. Helps to remove interstitial fluid, allowing tissue decompression. It helps to remove infectious material. It provides a closed, moist wound healing environment, promotes flap and graft survival, both hospital and domiciliary use. It reduces hospital stay. Contraindications are uncorrected coagulopathy, exposed vital organs or large vessels. The reconstructive surgery includes split thickness skin grafting, local and region flaps, microvascular free flaps, Other therapies include biophysical treatments, direct electric stimulation, pulsed electromagnetic field, pulsed radiofrequency energy. Phototherapy treatment includes infrared, laser, and ultraviolet. Next is the wound care management. It includes 7 steps. First step is assess, identify and address all issues, inspect and evaluate the wound for location, length, width, depth, check for undermining, check for tunneling. Next, the exudate, assess for drainage, color, serous, virulence, sanguinous, then odor, amount, consistency. All these things we have to assess. Next is tissue appearance, whether it's granulation tissue, slough tissue, necrotic tissue, like that. Then the color and moisture level we have to assess. Next is the peri-wound, whether it is intact, macerated, then infection, bioburden, edema, erythema, warm wound, odor, patient has any fever, any level of pain. All these things we have to assess. Next, cleanse and irrigate the wound. Remove debris, exudate pus and free-floating bacteria. Make the wound easier to see and evaluate. Then protect the peri-wound. Prevent the wound from increasing in size. Clean with the saline solution. Then fill the wound. Prevents pockets of abscess from forming. Gauze forms, other fiber and alginate gels we can use. Antimicrobial agents we can use for fill the wound. Next, cover. Apply protective dressing. Clean moist wound bed, granulation healing and closure, prevent infection. Then secure. Apply secondary dressing, promote healing and protect the wound. Then evaluate the healing process. Healing, regressing, no changes, new signs of infection, addressing is on place. These all things we have to evaluate whether the wound is healing or not. Next, management of stage 1 pressure ulcer. Manage incontinence, keep area clean and dry, use moisture barrier cream, offload area of pressure with the pressure reducing or distributing surface and turning and repositioning schedule. Ensure the heels are floated at all times with the frequent monitoring. Management of second stage pressure ulcer. If it is dry wound, cleanse with the normal saline, apply a small amount of hydrogel, then offload the area, change the position. If it is minimal discharge, cleanse with the normal saline, apply hydrocolloid dressing. In third stage, minimal discharge is there, then cleanse with the normal saline, apply hydrogel cover, offload the area, turn and reposition. If it is slough with the drainage, then debradement, use foam, slough is 30% or less, then negative pressure wound therapy. Next is stage 4 pressure ulcer management. If it is minimal drainage and clean wound bed, then cleanse with normal saline, apply hydrogel cover, then offload the area, then turn and reposition. If presence of slough is there, then sharp debridement, use foam, slough is 30% or less, negative pressure wound therapy. Tunneling and undermining shall be filled appropriately. Next is the algorithm for pressure ulcer. This is the algorithm. Next is preventive measures for bed sores. The skin is carefully inspected for any damage or redness and should be kept clean and dry. Confirm the high-risk patients and daily examination for the signs and symptoms. Relieve pressure by using special mattress, beds and comfort devices. Change position second hourly and give in back care 4 times a day. Loosening tight bandages and restraints. Avoid friction by providing smooth, firm and wrinkle-free bed. Then prevent moisture by changing linen. Giving back care to patients immediately following micturition and defecation. Avoid mechanical or physical injury to the skin. Use a bed cradle to lift the weight of bed linen off the patient to enable him or her to move in bed freely. Supply well-balanced diet and adequate fluids to maintain general health of the patient. Newer research include growth factors and cytokines have a big role to play in treatment of pressure ulcers in future. Then hyperbaric oxygen therapy. It increases oxygen transport to wound area, stopping further tissue damage. It facilitates growth of new capillaries, improving the microcirculation. It relieves pain, it speeds up wound healing by reducing inflammation of swelling. It reduces infection by eliminating bacteria. It improves microcirculation. It enhances the effect of some antibiotics. It stimulates the release of stem cells from the bone marrow. It decreases blood viscosity and risk of thrombosis. It improves bone density and mineralization. It enhances peripheral nerve regeneration. It prepares tissue and bone for grafting. Next is skin graft substitutes, connective tissue matrix, expanded epidermis, epidermal stem cells. Next is bone marrow or adipose tissue derived stem cell therapy. Complications include cellulitis, bone and joint infections, cancer, sepsis. അപ്പോൾ ഇത്രയുമാണ് എൻ്റെ ടോപ്പിക്. നിങ്ങൾക്ക് ഈ വീഡിയോ ഇഷ്ടപ്പെട്ടെന്ന് കരുതുന്നു. അപ്പോൾ ഇനിയും ഞാൻ ഇതുപോലത്തെ വീഡിയോസ് ഇടുന്നതാണ്. നിങ്ങൾ കണ്ടിന്യൂസ് ആയിട്ട് വാച്ച് ചെയ്യുക. താങ്ക്